Okay. Well, my pleasure to introduce Tapan Vat, who is the CEO and founder of TeraCrunch. They have done a number of different kinds of applications in AI and uh, have touched on health significantly. So, very interested to hear what Tapan has to say. Tapan, would you like to take off with us?
Thank you. I appreciate it. Can I share my screen here real quick?
Yeah, please. I'll make sure. Yeah, there we go.
Can everybody see this?
Yes.
Awesome. Well, thank you guys again for taking the time. Appreciate it. I'll probably walk you through a quick introduction of TeraCrunch and maybe a couple of case studies just to show you guys a high-level overview of the kind of work we do. So our mission here is to empower organizations with turnkey AI solutions that's built on the precision of machine learning and innovation of generative AI, where we are focused on solutions where off-the-shelf products and platforms fall short, driving substantial transformation for our clients. And I think most importantly, given today's day and age, we're committed to responsible and ethical AI, ensuring unbiased algorithms and transparent use of data. So we want to make sure whatever we do, we're very transparent about how we are using our clients' data. And also, we make sure that the algorithms that we are building and training are constantly unbiased. And as a result of which, our customers are extremely happy and, there's a transparent, honest, connected relationship there. Just a little bit about us. We've been in the business for 10 plus years now. We're closing 11 years this year. So with the pedigree of team we have, we're considered McKinsey of AI, but at the fraction of the price point. We are definitely not just the most experienced company, but also one of the most successful AI companies in the country right now. We've built about 150 plus solutions, delivering 5 to 40x ROI. We've worked with hundreds of businesses over the last 10 plus years. And over the years, I think what we've done is we've built, a secret sauce that's a blend of proprietary methods and pre-developed tech stack. So these methods and tech stack allow us to build custom solutions fairly quickly, also allows us to maintain and manage and fine-tune solutions in a very efficient way. And we guarantee ROI and a risk-free start with a complimentary viability assessment. It's a part of our methodology. High level on our services. Again, we are an AI company, so AI consulting, building and managing AI solutions is the key part of what we do. But I also believe that software and AI is merging, and it's merging at unprecedented rate. So what's going to happen over time is every single piece of software is going to be embedded with AI. And so AI is going to sneak into products and services regardless of what the product and what the service does. And one of the things I wanted to make sure was we build a team of software developers and software experts along with our AI experts so that when our clients need those kind of services, we're ready to go. And I've been saying, I think over the last year, probably year and a half, especially since ChatGPT has launched, we've seen a lot of convergence happening in the software and AI direction. So at a high level, we do AI consulting. We help companies build strategy and roadmap. We help them with use case identification. Use case identification is a really important one because we've seen a lot of companies trying to struggle in which direction we should go forward with. Should we pick this use case versus that? Is that a high value, low hanging use case, et cetera, et cetera. So we have a specific methodology that we use to identify the most powerful yet low hanging use cases. I talked about data viability assessments, basically making sure you've got the right data to be able to solve a specific problem. We support research and also a lot of AI ethics. And then building and managing AI solutions is our bread and butter. Everything from machine learning, Gen AI, LLM, computer vision, predictive analytics, chatbots, and then data integration, preparation, and AI ops is something we do. And then you can see the list of all the software services we provide for digital transformation. Before I go into the case studies, just wanted to give you guys a high level on some of the solutions that we've built. Now, we offer there are two things that we offer from a value proposition perspective. We come in with a portfolio of ready-made solutions. There are solutions that we've already trained algorithms on. We know what the input data needs to be. We know what the output will be. We know what the ROI would be, et cetera, et cetera. So we come with a portfolio of solutions that we can fully configure and customize to your data in a very, very short time. And the huge benefit that our customers usually get from this is quick time to market and definitely much lesser cost than building something custom. So we're focusing on patient care, as you see here on the left-hand side, everything from value-based care, risk stratification, to remote patient monitoring, chronic disease management, supporting research and innovation with AI, and lots of other examples as well, but these are just a few. And then on the marketing side, which I know is often overlooked domain in the healthcare industry, but with AI picking up, it's really becoming one of the core areas for healthcare companies to focus on. So as an example, AI chatbots for patient engagement, that's a big one. Patient segmentation for tailoring marketing strategies, and then personalized patient engagement to communicate very, very proactively in a very personalized way. And then one of the biggest areas for growth for us in the healthcare space is automation. These are automation of repetitive, mundane tasks. These are automation of tasks that are administrative in nature, and pretty much anything that humans should do, could do, but should not do, because they can put their time and effort in something much more meaningful than doing the same thing again and again every day. So there's a variety of different things here: automated eligibility verification. There's debt prediction modeling, chatbots for billing inquiries, smart appointment scheduling, demand forecasting, and then fraud detection. And just so it's clear here, we are offering the solution not just to payers and providers, because most companies, most folks think we are really focusing payers and providers. This is across the board. So we work with healthcare tech companies, we work with healthcare startups, we work with medical devices companies, we work with research organization, et cetera, et cetera. So I'm going to walk you through a few case studies here. The first one, I know this is a very wordy slide, but this is meant for someone to read. So what I'm going to do is kind of, read here, so we are all following the same thing, and then happy to open up for any questions. I have one more case study to cover after this, though. So as we all know, the healthcare industry is facing a challenge in aligning value-based care models that prioritizes high quality, patient-centric, and cost-effective treatments. Our goal is really to use AI to transform healthcare data into predictive insights for predicting patient risk. And this initiative is crucial for early intervention and personalized care strategies, ensuring that resources are optimally allocated to those in greatest needs. So our solution here is essentially predicting patient risk score, which is, I wouldn't say it's the newest thing on the planet, but the way we have leveraged this with LLM and historical clinical notes and everything else, that's the key here. So essentially what we've done is we've leveraged historical claims and behavioral data, and we've developed predictive models that also takes a lot of clinical notes data to prioritize and predict patients that are at risk. So this model enables early intervention, reducing the likelihood of emergency treatments and hospitalizations. I think our tailored care strategies based on individual risk profiles ensure that each patient receives the most appropriate and personalized care. And what we're essentially doing here is we're providing weekly user-friendly risk reports. So daily, weekly, and then we're essentially empowering care teams to make data-driven decisions to allocate resources effectively. So this is not only boosting care teams' productivity, but it's also significantly enhancing patients' health outcomes, and that directly speaks to the value-based care. We've seen amazing results as a result of the solution that we've built, and this is, I think, deployed across, I would say, about 70 plus hospital systems in the country. We've reduced emergency department encounters. As you can see here, 17% reduction in ED. It's not a statistically huge number, but if you think about it, it's definitely a trend towards reducing emergency department encounters over time. I think our hope is we get this number to probably higher 30s, higher 40s, which is significant at that time. Reduction in hospital readmissions. We've seen readmissions within 90 to 180 days decrease. There was also a 71% reduction in 90-day readmissions and 52% reduction in 180-day readmission in the intervention group that we had used for the study. Definitely very statistically significant findings here. And then decreased emergency medical services encounters were 47% lower in the intervention group here, suggesting effective preemptive healthcare measures can reduce need for emergency interventions. So great case study. We've seen tremendous impact in patients' health. We've seen tremendous impact in hospitals and how they care about their patients, and also all these different result numbers, as you can see. So very excited to take this to other hospital systems and both payers and providers. We've actually deployed this for payers in the past as well. They need the same thing. So one of the things we've seen is payers are now very much embracing a lot that providers are, and vice versa. So exciting times for AI, because now you can target both those parties at the same time with similar solutions. Any questions here, by the way, before I move on? I'm going to cover a different case study and then open up for Q&A. But before people lose their train of thought, I can stop here for a second.
I have a quick question. How are you contemplating cybersecurity in your solution? I didn't see a clear call out on that.
Yeah, we are essentially doing two things. One, we are asking our clients to remove PII before sending us any data. So they replace PII with any individual identifier. When we bring the data in our Azure cloud, obviously Microsoft Azure, we use them, and we use all the bells and whistles from a security and privacy perspective. But once the PII is out, it takes away from a lot of responsibility from our side. That's one area. I think the other way for us to deploy solutions, and this is something we've done in the past, is we're deploying clients, our customers' cloud. So once the solution is built and trained, the deployment actually happens on the customer site in their environment.
Thank you.
So the implication of that, Tapan, is that of the customer cloud is that you have a circumscribed large language model. Is that right? So you're not going outside that as your model?
That's correct. I think one of the big things we have done is instead of leveraging OpenAI and some of this more popular LLM models, we're leveraging open source LLMs. And that allows us to take everything in-house, set it up in a secure Azure cloud. And then every single deployments that we usually have is dedicated for that specific customer only. And then even for that customer, the only people within our team or otherwise would ever touch that are the folks that are actually on that project. Usually it's a lead data scientist and an engineer.
So I have a quick question, Ryan here. So what libraries or volumes do you have accessible to your clients? Um, uh, I'm only asking because, in my opinion, or it seems a lot of times that the only way to really do that is with blockchain and proof of origins. There are a lot of open source libraries, but to be actually ethical, I'm wondering what libraries you use and how and proof of origins they have.
Yeah, I mean, some of these libraries are open source codes are provided by some of the biggest players out there. There's Google, there's Meta, there's obviously Microsoft and OpenAI and many others. And the library selection depends on the kind of problem that we're solving. Not all libraries are similar, and each one will be each one is focused on solving specific type of problems and working on specific type of data. So I think the vague answer to your question is it depends on the problem you're solving. There are dozens of libraries out there. So there's no specific one library that we use for a problem. I think it depends on several different factors and a methodology that we use. Yeah.
Oh, you're talking about, okay, programming libraries. I was actually talking about AI volumes that maybe your clients have access to use for your products. Is it just their own information, or do they use chatbots and things along those lines with information from unverified libraries and things along those lines?
Are you asking me if the customers are leveraging outside data?
Yeah, well, yeah. Or you said that you had AI Azure clouds. I didn't know if that was to store data or processes for your clients. So you don't really store any of the data for the clients.
No, we do. Again, we do store the data, but what we recommend our clients to do is take the PII out. PII is personally identifiable information. So that way I know this guy is ID number of 14678, but I don't know this guy is tapping. I don't know where this guy lives. I don't know what his age. So anything that's PII, we ask them to take out. And then in terms of data.
So it's a digital identity.
Correct. And then in terms of data, we're usually using our clients' proprietary data and then working our AI on their data. There may be scenarios where we might bring some third-party data to bear, but that's a rare case scenario.
And the patients, do they have open access to their ledgers? Do you know about, or is that like really a per customer request?
Yeah, we let our clients decide that because we don't own the patient data, our clients do. So it's up to them to decide how they want to expose those ledgers to patients.
Thank you.
Great. Thanks, Tapan. I think we can go on.
This is really interesting, and I think it's something that's it's going to take a lot of momentum over time. This is an automation use case where patient scheduling is being optimized. It's one of those areas where patient scheduling is so far up until we deployed and launched the solution. Patient scheduling has been very much a nature of, hey, when you call, you're in a queue, and based on when your turn comes, you're being scheduled. But that's a very inefficient way of scheduling and managing patients. So here's a new innovative AI-driven solution to manage patients. What we've done is we have essentially, one of the problems we've solved is long wait times for patients that are really needing to see a physician more urgently than others. It also solves for underutilization of healthcare resources and provides one of the best patient experiences ever. So anyways, there was a need for intelligent scheduling system that can dynamically allocate appointments based on needs, urgency, and resource availability, right? So it's not just what the patient needs, but also where the provider's availability is in terms of resources and staffing and so forth. So it's a combination and marriage of those two different things. So this system integrates seamlessly with existing healthcare infrastructure, support decision-making for healthcare providers, and it enhances patient satisfaction by reducing wait times, and improving access to care. So the solution we built it goes with the first step is an online form. Patients complete an online form whereby they're supposed to enter details about their symptoms and medical history, if there's anything new from last time. Then number two would be the data integration. Our machine learning models and system would integrate this data with existing medical records to create a comprehensive patient profile. And then our algorithms will analyze this patient data, consider factors like symptom severity, medical history, health metrics, doctors' availability, etc. And then it provides recommendations on in-person visit versus remote, what should be the priority level of taking that patient, and so forth. And then it sends instant notifications to patients. So they receive immediate text or emails with their appointment details. And we also alert healthcare professional to schedule and prepare for upcoming consultations. So wonderful thing we saw from a result perspective, obviously, as we had predicted, we'd see decreased wait times, but to our surprise, we saw 30% reduction in wait times across all the patients. It was a huge one. We also saw increased provider productivity. So this system's inefficiency in appointment allocation resulted in 20% increase in overall provider productivity. And then a really think a powerful KPI is optimized resource utilization. Hospitals are, they are really not sure how they can tackle this huge problem of supply and demand that's going on right now, especially post-COVID. So one of the biggest things we can do to help them is with resource utilization in an optimized way. And then that was a third big result we saw. We saw 25% decrease in idle time for medical staff. And so they could achieve a lot more with the same amount of staff. And, so as a result of that, I think the patient scheduling and management was improved, but more importantly, the staff time that was underutilized is now being utilized in a very intelligent, smart way. So a great case study. Very excited about where we can take this in the future.
Hey, Kaplan, this is Dr. Baran from University Health. How do you do all that without having direct access to the EHR, the scheduling system, to PeopleSoft tools that we use to allocate resources?
Yeah, so we asked our provider partner to create extracts from those databases, so we don't have to integrate directly into the EHR system.
So you're dealing with stale data all the time, right?
Say it again, please.
You're dealing with stale data, in other words.
The extracts are created on a regular basis. So we have a specific time window in which those extracts are created on I would say on a half an hour basis. So it would be stale for 30 minutes, but I think it gets updated every 30 minutes. Okay. And then our recommendations are going back into those servers, and then they have backend integrations into their systems, obviously. So that way we kept away from integration because they could take a long time. And also it could be an IT upheaval that battle that nobody wants to tackle. So a better way for integration would be to do what we just did, which is to ask them to create extracts, and then we integrate and extract data from those extracts directly. That way you're not messing with the backend systems. We could also,
These
we've
are very,
also, go ahead, sorry.
no, these are very powerful examples, Tapan. I'm really amazed. Are there um, are there infrastructure implications of doing this? You know, compute power and hardware and so on.
Definitely. So I think the biggest compute power requirement is when we are training the models. When we're training an LLM model or machine learning model on large volumes of historical data, is when we need the highest computational power. I think once we are in deployment, we don't need all that data. We need just the newest data and very specific variables for us to provide the outputs. So there is definitely computational power requirements, but I think it's limited during the training data or training time frame.
Other questions? Well, Tapan, you've put your contact information there. That's great, so that people have an opportunity to follow up if they can. Will that be okay?
Yeah, absolutely. You know, we definitely encourage very open conversation. I'm always happy to talk to not just partners and customers, but anybody in the industry that's trying to figure out AI, trying to see what AI can do for them, explore AI. We're happy to help them. I'm definitely one of the biggest proponents of local partnerships and local relationships. So if anything we can do to help you, please reach out. We typically tell our partners and everybody else that engages with us, we basically start in 3 easy steps. We identify a high value use case. If you don't know which one to start with, we can help you with that. We assess, which means we provide a free viability assessment before we even say we can do something. We will make sure we review your holdings and decide next steps based on that. And then last one is we design and build solutions in 8 to 10 weeks.
That's a very accelerated time frame. That's great.
Yeah, and people ask us, how is that even possible? And we say it's because we've been doing this for 10 years. We have methodologies in place, we have tech stacks in place, we have code that we've built in place, we have algorithms that are part of our portfolio that's in place and trained on large volumes of data. So you're really coming to a shop that has a lot of stuff that's already ready-made. So we're really working on the 20%, the last mile only. And a lot of the work has already been done.
Yeah, that's great. That's a great model.
Top, and where are you based in town?
We are in Leawood, Kansas. We were in College and Knoll.
Anything else, friends? Okay, thank you very much, Tapan. That was really great. Look forward to engaging with you further.
Thank you, guys. I'll stop sharing my screen here.
Okay. We have the opportunity to maybe have people say hello who joined us since we started. If you'll just kind of give your name and your organization, that would be great. I see Anil here.
Sorry, this is Anil Chauhan. Sorry for joining a little late. I'm a professor of radiology, vice chair of AI at University of Kansas Medical Center. So got an invitation, so happy to join here.
Great to have you. Thank you for joining us. Bill Saltmarsh.
Morning, everybody. Sorry I was late. Chief Data Officer at Children's Mercy Hospital.
Great. Juan.
Morning, everyone. Juan Corona, head of growth, head of sales at a healthcare IT company named TeraCrunch Solutions.
Great. Is Aaron still with us? Aaron Deacon? Okay. Great. With that, let's go ahead and with our next presentation from Steve Sewell and Sinochips in diagnostics. Please tell us more, Steve.
Fantastic. We'll make sure the share screen works first here and get that going.
Yeah.
Put it in presentation mode.
Perfect.
There we go. Well, thank you very much, John, and great presentation to happen. Glad to share the agenda with you today. I'm also very excited to introduce Dr. Zian Pacetto, who is on our call today. Zian is our lab director and our chief scientific officer, but she's also one of the co-founders of Sinochips. It's a full service reference lab based down on the west side of Olathe off of College Boulevard. And what she has built over the last few years is truly impressive and something for Kansas City to be very proud of. There's not a lot of awareness of the company and the capabilities. So what you see with Sinochips is a full reference lab who is also offering pharmacogenomics, and that's what we're going to talk about today. What we call a revolution in personalized medicine. But before we do that, I think it's important. I think this is the first meeting, John, since the Chiefs won their back-to-back Super Bowl. So how about those Chiefs and the fact that they were able to 2 in a row and been there 4 out of 5 and have won 3 now in the last few years. It's a dynasty in the making, and more to come, we all hope. But I think it's a nice little tie-in too, because if you're involved in NFL football, or you're a fan, or you're involved with digital health in some capacity, where would you rather be than right there in Kansas City? So I think it's a pretty exciting time for Kansas City in a number of ways, and we'll use that as the segue over into pharmacogenomics. Where I want to start with this is talking about a what if. What if there was a technology that would reduce the rehospitalizations and ER visits and overall mortality? What if there were ways to decrease opiate prescriptions, especially ones that are not optimized and don't work? We all know that there's associated addictions when people are put on prescriptions. I think the most recent stat I've seen is 5 to 6% of individuals that are prescribed opiates post-op will develop an addiction. So some critical things that can happen there. Significant reductions in reported symptoms with fewer side effects. And what if we had technology that avoided unnecessary deaths? And the best part of it is that there are improvements in outcomes, because that's what we're all trying to do. We're trying to get better outcomes more efficiently, lower cost. Well, shouldn't we implement that if it exists? And it does. And we can today with pharmacogenomics. And one interesting statistic in this category is the fact that all of us have genetic variances that impact how prescription drugs work in our system. And if we know those predispositions, we know we can save dollars and lives, and we can improve outcomes, and that's personalized medicine. So in the simplest definition, what is pharmacogenomics, or also called PGX? It's the utilization of genetic insights to optimize prescription medicine. Again, almost all of us have genetic variations that impact how a given drug can impact our effectiveness in utilizing those drugs. And that's where the PGX comes into play. And it works in 2 different ways. Those gene variants can influence both a drug pathway, but typically and most usually it's associated with metabolism of medications. When you think about it, when the pharmaceutical companies do all their research and they've identified a drug that can work in a given situation, then they go ahead and put their standard dosage recommendation together that says, all right, take 2 ibuprofen or 2 Tylenol or 1 Aleve. And that's based upon the fact that the majority of people are going to respond to that in a way where that's the appropriate dosage. But given the old Pareto rule of 20 or 30% of individuals might need a slightly different dosage. And we'll talk a little bit more about that. But the second piece of that is the core elements of it's a core element of precision medicine, and it's designed to enhance an individual's response to medication, and it can help clinicians prescribe the most appropriate drugs and with the optimized dosages. And all those things result then in better patient outcomes. I'm going to move the screen here just a little bit. So what you see here on the left-hand side of this image is basically just all the different, a lot of the different factors that need to be taken into consideration by a clinician when they're assessing an individual and how to optimize their healthcare. And they're looking at the multiple health conditions that that individual might have, but they also have to look at things like lifestyle factors and demographics, drug-food interactions, the other omics, the environment that that person is living in, and then genomic variation. And when they're looking at that, you look at the screen, if you take the standard approach, which most doctors are still using, then when the patient does require some kind of medication, then they're going to go with their best estimate of what is going to work. Most doctors are going to have a standard regimen in response to a given indication, and they're going to see how that medication works. They're going to monitor and watch for adverse drug reactions, look for toxicity. They're going to look at whether they're getting the outcome that they're wanting, and through a little bit of trial and error, a little bit of a pinch of this and a pinch of that, maybe give another drug in order to offset side effects from the one that they prescribed. They try to get to the point where that person is stabilized and they're seeing the outcome they're looking for. But with the new approach that's available with PGX, you do the testing ahead of time. You rule out the drugs that have a high risk of side effects or is associated with that individual's variants of their genome to say, I have a better drug alternative. I have a better dosage alternative. If that person is a fast metabolizer of a certain drug, then either use a different one, or you may have to increase the dosage or be prepared to increase the dosage if you don't see the outcomes you're looking for. So with that prescription optimization, you can see medications that you simply don't need to give anymore, or the dosages can be either lowered or increased. So why should we care about pharmacogenomics? We've talked about several factors already, but how can clinicians make the right decisions and implement optimized treatments when they don't have all the information available? And doctors do try to get to some of these insights by asking about family history, by asking about previous experiences. But by running this test, which in the whole scheme of our healthcare system is a relatively minor investment, then clinicians do have this additional information at their disposal to be able to optimize. And I took it one step further. I actually think that when we look at the Hippocratic Oath, I swear by Apollo and all the gods and goddesses that according to my ability and my judgment, I will keep this oath to follow that system, a regimen which will benefit my patients. And I think that that carries even a little bit further to the point that we're almost obligated to start using this medicine, this new system that allows us to avoid trial and error. It allows us to speed up and optimize prescriptions. There's an example that was given in a presentation recently that I saw that said that between the first indication of an issue with mental health and the first intervention is over a decade. For individuals that are experiencing those kinds of issues, it's almost a decade before they finally get some help. But to me, that's not even the worst statistic. The worst statistic is that once they initiate some kind of intervention and activity, that over 50% of those interventions fail for mental health patients. Well, in many cases, by running a PGX test, you might be able to find that associated with their metabolism or a pathway or whatever reason that you can actually have an improved outcome associated with that mental health patient that's been waiting for so long. And I had an interesting conversation with a clinician, psychiatrist, who said that, yeah, he said it's, when I tell a patient that we might see some side effects, he goes, the odds of seeing side effects go way up. And so I asked him, I said, well, so you're talking about the power of suggestion. You suggest they might see some. He said, that's what happens. I said, well, what if you can do the opposite? What if you can tell this patient that you've ruled out some medications that have the worst side effects based on their variants and their genome? And so you're going to give them precision medicine. You're going to put them in a situation where you have a reduced likelihood of a side effect. Then aren't you going to see some benefit there, or could see some benefit there? And he acknowledged that yes, and that with that placebo effect, you're telling the patient they're going to see some medically validated improved outcome, and it improves the odds there as well. But what it's not is not perfect. We know that not all drug, all the research that needs to be done hasn't been done yet, and not all drug gene interactions are clinically actionable. More testing needs to be done, and that's typically in the report, the level of evidence, the criticality of the action step needed to take. And in addition, there are ethical and societal concerns. We're capturing a lot of information on individuals. There's a lot of data out there. That's something that needs to be monitored. We have continued investment. Research organizations across the world are making significant investments in doing this. All the pharmacology companies, when they're pharmaceutical companies, when they're trying to get a new approval, there's more genetic insights that are being provided. Countries in Europe and in Asia are ahead of where we are in the United States. There's good insights there. But ROI is not a given. If you do this on a healthy individual, you may not get a short-term return on investment. On the other hand, having that information available can be valuable for even someone that's healthy, because when in fact something does happen, when they have that information at their disposal, they're going to have an improved outcome. But there's also changes in workflows that are going to be required. I know that presentation that Greg Ator gave at a conference recently, he was talking about the amount of time that doctors are all, and clinicians and nurses, pharmacists are already spending on interaction with their different software systems and health record systems that they're utilizing. And to have another one that they need to reference is a challenge that has to be addressed. And then there's other complexities. There's something called phenoconversion, where if you take a certain drug, it can actually influence the response of a drug that according to the PGX system said was going to behave a certain way, and now it doesn't because of the interactions of those drugs. So there is more information still being developed, and but it is one of the technologies that we'll be using more in the future. One of the most exciting things about what we offer at CenoChips is not just a physical PDF, a report, something that can be opened up on the screen, but you can also have a dynamic online portal access, which is user-friendly. It's constantly being updated. Physicians can update it with new drug regimens or new indications, lifestyle changes, as I mentioned before, so alcohol or smoking, marijuana, etc. I noticed that in mine it said the sugarholic part definitely was something that they were asking about. But it's secure and it's accessible and it's designed for healthcare professionals. But this is the front page of a physical report, which allows you to log into the online portal. At that point, you have the opportunity to put the different things I just mentioned in as far as the demographics and lifestyle. Once you've done that, you go ahead and you put in the drug regimen, which drugs is this person currently on. And as everyone knows, polypharmac is something that is typical, especially in older populations in the United States. So having all that information in there, you then are able to click on the report. And when you do that, two pieces pop up. One that's associated with the side effects that an individual on those medications is likely or possibly could see. And then the report on the right, which is getting into the actual risk reporting of that individual with those drugs. And so this is a cumulative way of looking at it, where you have the FDA black box warning, the drug to drug interactions, that's also reported on here. Some other components, but what you see is the blue bar there that's talking then specifically about genetics, and this being the only source of data or source of information on that piece. But what's really exciting is at that point you can go ahead and then check on and look at alternative drugs based upon trying to lower that overall risk profile. So in this case, the person has 40 points on warfarin, and so you're able to look at alternatives and find out if there are things that could lower that individual's overall risk profile. So what's possible? Well, we have case studies showing a healthy male. He was treated for rib injuries at the ER, but based upon having his report with him, the trauma doctor, instead of giving him opiates, which he's a fast metabolizer and doesn't provide the pain avoidance that you're looking for, did alternative medications instead. We also have cardiologist patient that was able to avoid a problematic statin that the system said was likely to cause significant side effects. We have seen where transplant patients prescribed immunosuppressants. They're typically going to go lower dosage on those just to avoid issues. But by knowing ahead of time that this person has the genetic variants associated with that, they can go ahead and move to an optimized dose more quickly. There's anticoagulant dosage improvement instead of having to do trial and error of a critical blood thinner. And then there's chemotherapies out there that certain individuals with given genetic variances that can be life-threatening if they're put on that. And so you can identify that and avoid it ahead of time. And then back to what I mentioned as far as with the psychotropic drugs and the psychiatric patients, getting to first time right. Studies have shown over and over that they can have significant reductions in ER visits and rehospitalizations and get to improved outcomes more quickly. So why should you learn more? Why did John agree to put me on today? Because it does because the people that are on this call, there's an awareness factor. More clinicians need to be aware that this is currently available within the arenas of pain management, mental health, and cardiovascular. There are evidence-based outcomes that can be identified today. So we're hoping to improve personalized medicine, allowing clinicians to tailor treatment plans based on their genetic profiles, and we can also mitigate that trial and error prescribing. In addition, it does reduce healthcare costs. It's been shown over and over, and in fact, that was a key factor in Medi-Cal just agreeing last year that they're going to start covering PGX in California for the Medicare patients in April. In the situations where it's medically justified, and you see broader acknowledgement within the overall Medicare system as well. But we can identify patients at risk of adverse drug reactions, preventing those unnecessary hospitalizations, rehospitalizations, and ER visits, and more quickly getting to optimized regimens so you have fewer follow-up appointments. Another statistic that's been shown by several of the individuals on this call and in their previous presentations is what everybody knows to be a significant shortage of healthcare workers. Well, when you're running people unnecessarily back into the ER, when a psychiatrist is seeing a patient multiple times just to try to get to the appropriate optimized prescription plan, then by incorporating PGX, we improve the likelihood that we're going to use the resources we have more effectively. And I think that when Dan Cranshaw, I saw heard his opening there about some of the community responsibilities he has. I think all of us have to be aware that as new technologies come to bear, that it's not unusual for us to have disadvantaged parts of our communities that don't get full access. And so by being aware of this and by making sure that our healthcare professionals are knowledgeable on PGX and the implications there, we can do a better job of making sure that we're offering PGX in an accessible way. So what else is needed to increase adoption? Well, we just heard from Tappan, and incorporating AI, or at least a simple version of that, We had another individual on the call today. I think has joined us from Epic. So I know that they're working in this arena to make sure that this is not another system and another process that clinicians have to build in and add time for. It needs to be proactive. We need AI, we need the alerts so that care providers don't have another system to reference. So just a little bit about Cytochips here at the very end. We are pioneers in PGX testing, offering personalized genomics-based medicine. We have sub-panels on mental health, pain management, cardiology, but typically we're going to go ahead and provide that as a comprehensive panel because it just makes more sense when you've got medications from the different categories that are all going to be coordinated within that panel. Cutting edge tech as far as the online portal, instantaneous drug regimen adjustments. We're here in Kansas City, so offering quick turnaround times, being able to enhance patient care. There's only a dozen or so labs in the United States that have an approved Z code and CPT code with Medicare. And that's one of the most impressive things about Cytochips is that here in Olathe, we have one of only a dozen labs in the United States that has that certification from Medicare. We've done studies that show that, or we've done comparisons to some of the other providers out there, and we have genes that some of them, evidence-based genes, that some of them simply haven't been able to incorporate yet. So some advanced capabilities here from Cytochips. And we're also a clinical studies supporter. On our website, there are several clinical studies, several with the University of Kansas and a couple of other locations. That show where we're supporting work in a number of different arenas. As far as that panel I mentioned, 27 genes, 87 SNPs, 54 drug classes, and 222 drugs that are included in the reporting that we're using today. So with that, John, that's a quick and dirty on Cytochips Diagnostics. We're a full reference lab down in Olathe that is focused and prioritizing pharmacogenomics.
That's great, Steve. Thanks very much. I was just, as a layperson, I guess, interested in really who do you view as being the client, and how does one kind of on board for this solution?
So there are a number of companies that are offering PGX services online. I mean, 23andMe is one of the has some elements of that in what they're offering even. So there's a number of providers that are even offering this straight to the consumer. The FDA is currently going through their evaluation and trying to ramp up and catch up with industry. Their preference is that providers like Cytochips are targeting the clinician and working through the doctor and the pharmacist for to implement optimized medicine. There's real concerns out there that someone will misinterpret the results and see that they have a low risk or have a issue with limited scientific validation, and we'll stop taking a medicine or something. So we do work through clinicians and through health systems, and that's what we're targeting is rolling out that way.
Great, thank you.
Steve, what is the cost? I'm sorry, I don't know how to, is there a hand raising thing here? Steve, what's the
You're
cost?
talking,
of the
you're good,
panel?
Stan.
I'm sorry.
So like anything else in the medical industry, there's the cost and then there's the price. And what you see with pharmacogenomics is that the Medicare reimbursement rate is going to be at the near $1,000. The price to the consumer from based upon insurance is going to vary by those insurance providers around that number. There is an out-of-pocket cash alternative for those that are refused coverage by their insurance provider, and that number is going to be in the several $100s.
Thank you.
Dr. Troan?
Yeah, thank you for presentation. Like, it's always good to hear about the genomic side of it. And in the imaging side, I just wanted to put a couple comments. So one thing that happens, like it's already happening. So not as such pharmaco, but there is a lot of these genetic testings now helping finding these mutations with extremely low risk of malignancies. And we are doing a lot of these scans on these patients with like pretty much 99.999% of like normal rate. So we are actually, there is always a risk of overdoing things. And now like we are basically spending more healthcare dollars on doing these tests, which may not be necessary. So I think you're right, like data needs to come out and we need to really figure out the true risk. But one question I had is, in your data, like, do you know if there's data out there? I know you compare with the standard care and pharmacogenomics, but what about taking the genetics out of the picture and actually doing an algorithm-based analysis? And there is already a KU study on mental health, antidepressants. Taking all the environmental demographics, a bunch of patient past medical history and all that data, and then create an algorithm based on that, and then finding the optimized solution, and then compare that with the pharmacogenomics. So that will be the true testing, as in, is it how much of this is helpful? Do you know if there is a data out there where there's a pharmacogenomics, how much is that is adding to the existing non-genomic algorithm, which actually already exists in the EPIC or medical chart system?
So a lot there in what you just said. I guess I think I would start first with differentiating between, as you said, the pharmacogenomics and the actual disease genomics, trying to identify if someone's carrying genes that increases their risk profile. A perfect example of that is some of the breast cancer research that's done, the BRCA genes. And yes, when you look at the expenses by Medicare and within the health system, the dollars associated with any kind of diagnostic testing has significantly increased in the last decade at an unsustainable rate. And as Anil was referring to, it really is important to identify where you are getting the dollars, where you're getting a return on investment. And I think that his example in oncology is a perfect one, though, that if we're doing all the follow-up testing and unnecessarily doing that because of the low risk return ratio there. But I think that's a little bit different on pharmacogenomics, because it is a one and done type of thing, and you can also target that against the higher propensity categories. There are some population risk stratification tools out there that uses some of the data that Anil's referring to. So you can identify within a population the ones that you should still go ahead and do that testing with. You also have categories. So within, I think about 20% of psychiatrists are now using this. And when in the case of cardiology, it makes sense where you've got older patients, polypharm patients, where you can see the interactions of the drug to drug and the drug to gene. So it does need to be implemented in a smart way. It does not, it typically is not justified today to do it universally, but with some of that information at your disposal, it is, I think doctors can make good decisions on when they should go ahead and order the test.
Thank you.
Sorry, can I wait in for the question and provide some other answers to clinical trials? There was a large clinical trial done in Europe, started back in 2017, and the data was published last year, 2023. I believe it was February. There were 7,000 patients enrolled, and they compared with or without PGX intervention. And they found that 30% more efficiency if you have done PGX testing to manage the patient's drug interactions or other things. So there is a significant benefits of doing PGX. I don't remember the publication name. It was published in the Lancet, and the keyword should be U-PGX. If you Google that, it should pop up for that clinical trial. Unfortunately, I don't think the US has a large clinical trial like this so far. That's something we should do.
That's what I was coming at is the US, in addition, in just my own world, like I have access to way more data on the patient chart from through Care Everywhere than when I was a resident like 2010. So I think even though studies have been published in the past, the data is just so much now. I think these algorithms need to be remanufactured. I think that'll be, or just like you said, have a US data available will be much more helpful, especially now that we have access to the healthcare data from rural US much more efficiently now than it used to be in the past.
Yeah, totally agree.
Again, it is eye-opening to read the studies that are out there. There's the brand new one on cardiology that talks about the different factors with statins and beta blockers, the blood thinners that they did find positive ROI when looking at by incorporating PGX. And again, with mental health, the numbers are pretty significant as far as the individuals on reductions in ER visits and rehospitalizations. It doesn't take but one ER visit to offset a bunch of tests. So I think that the evidence is growing that, in fact, another study showed that 70% of the studies, so it was a overall review, 70% of studies showed positive ROI for PGX implementation. Now you're muted, John.
Yes, I am. Other questions?
Hey, Steve, and your colleague, I think this is part of the future of how we diagnose and treat patients. I think the question has always been, where does this fit? Who pays for it? And then how does it work its way back into the clinical workflow so that it's not an appendage, it's not what I call recreational genetics, where I get my report and I want to carry it with me every time I go see the doc, and I, slow down the process and those things. So it's very impressive that you all have built this in town with resources, and technology from around the world. So I think a big part of the success of this is trying to find what's the long-term business model and buyer for this technology. And I'd love to see more Kansas City health institutions take the chance. And we're trying to get this region to be an early adopter of these kinds of things, even if it's in limited use, but to try to support our companies locally. So that's a big part of John getting this on the call, just like with Tappan's company. But I would really be great if some of the folks on the call would, introduce you guys to friends and neighbors on that side of it. So, but good work.
Appreciate it, Dick. You guys are doing some great work, and we've had good conversations with several of the major institutions in Kansas City. And obviously, what you just highlighted and what Anil just mentioned as well, making sure that is incorporated into the systems in a smart way. I know Epic and Cerner are both working on that. KU has their initiative that they're doing. So they're trying to figure out, how do you do this in a way, making sure you do this in a way where it's integrated and helpful, and not another system as Anil said, I've got more data, I'm swimming in data today. Let's make sure we've got this done in an integrated way so that it is improving outcomes for the patient, and frankly, improving the work environment for the clinicians.
Great, thanks. Other questions from the team?
I will mention, John, that you saw that first case study. I'm that healthy male individual who, on the front end, probably doesn't justify having a PGX test. I don't take a lot of medications, and so don't have the drug to drug side of it. But I can tell you that my results came back and said that opiates are not a good option for me. I'm a high metabolizer. I burn them out pretty quickly, and it kind of explained why, over the decades of my life, with frequent accidents and having too much fun and suffering the consequences, that the prescriptions never really did the trick. And so when I told the doctor, the trauma nurse, a trauma doctor at KU, that with my 3 cracked ribs and my partially deflated lung and some internal bleeding, that maybe we ought to look at something other than showed her my results, she quickly pivoted to some old school cocktail of other options. And for the first time in my life, I actually had pain relief associated with injuries that lasted the duration of the time frame needed. So it's an interesting thing for all of you to think about how it could impact you and your family. Some great stories about some parents with children and being able to better understand which of those psychotropic drugs might be most appropriate, and being able to show them too the interactions with marijuana and with alcohol. So some really good things happening in the industry.
Great. I'm glad you had such a great experience. That's your own personal case study. That's great.
Yeah, and the learning experience of don't drive a golf cart too fast. It's that they can get out of control.
I'll remember that as I enter my senior years. Other questions from the team? Well, Steve, thank you so much. We really appreciate that insight this morning, and Tappan, what you shared was really powerful as well, and we're very grateful for both of you being with us. Look forward to seeing everybody at the Digital Health Innovation Forum next Wednesday evening at Pulcinelli, and also next month as we look at more solutions in the digital health environment. So thank you all very much.
Thank you for what you guys do, John. Appreciate it.
Yeah, thank you, John. Appreciate it. Thanks, Dick. Goodbye.
See you guys.
Bye-bye.
Thank you.
Thank you very much. Yes.